Weil-Felix test. Weil-Felix test definition and principle. The Weil-Felix reaction Weil-Felix reaction is a heterophile agglutination test traditionally used for the presumptive serological diagnosis of certain rickettsial infections. The test is based on the principle of antigenic cross reactivity. Specifically, it relies on the sharing of an alkali stable carbohydrate lipopolysaccharide antigen between same Rickettsia and certain non-motile strains of Proteus bacilli. Because they share this antigen, antibodies produced by a patient's immune system against the Rickettsia pathogen will incidentally cross-react with agglutinate the specific Proteus strains. So the test is based on the principle of antigenic cross-reactivity. Specifically, it relies on the sharing of an alkali stable carbohydrate lipopolysaccharide antigen between some Rickettsia and certain non-motile strains of the Proteus bacilli. Because they share this antigen antibodies produced by a patient's immune system against the Rickettsia pathogen will incidentally cross-react with agglutinate the specific Proteus strain. The test utilizes three specific Proteus antigens: Proteus vulgaris OX19, Proteus vulgaris OX2, Proteus mirabilis OXK. Procedure: the test is typically performed as a macroscopic tube agglutination test or a micro agglutination reaction in a microtitry plate. Serial dilutions of the patient's serum from 1:10 to 1:640 are mixed with equal amounts of the Proteus antigen. The tubes are incubated in a water bath at 37 degrees centigrade for 2 hours, followed by overnight incubation at 4 degrees centigrade. A positive result is indicated by the complete clearing of the supernatant fluid and the formation of smaller masses of agglutinated antigen at the bottom of the tube. Interpretation of result that the agglutination patterns vary depending on the specific rickettsial disease, allowing clinicians to differentiate between major typhus groups, epidemic and endemic typhus. The patient's serum strongly agglutinate OX19, may weakly agglutinate with OX2, and is negative for OXK. Patient serum strongly agglutinate OX19 4 plus, may weakly agglutinate OX2 plus or minus, and is a negative for OXK. Tick-borne spotted fevers, Rocky Mountain spotted fever, Indian tick typhus. Antibodies to both OX19 OX2 are typically elevated plus 2 plus, while OXK is negative. Scrub typhus. The serum strongly agglutinates only OXK 3 plus or 4 plus, while OX19 OX2 remain negative for scrub typhus. Negative result: the test is usually negative or only weakly positive in Brill-Ginser disease, that recrudescent typhus. It is completely negative in Q fever, rickettsial pox, French fever, ehrlichiosis, and Bartonellosis. Limitations and drawbacks: the false positives. Because it is non-specific test, false positive reaction can occur in patients with underlying Proteus urinary tract infection, relapsing fever caused by Borrelia, typhoid and certain liver diseases cases. False positives may come. False negatives. Projon phenomenon. Excessive antibodies in the patient's serum can cause a false negative result, which can be resolved by testing with serial dilutions of the serum. Requirement of paired sera. Antibodies appear rapidly and peak by the second week, then decline rapidly. Therefore, demonstrating a fourfold rise in antibody titer using paired acute and convalescent sera is much more meaningful than a single high titer. Current diagnostic status: because the Weil-Felix test lacks both sensitivity and specificity, it is no longer recommended as the primary diagnostic tool. Today, it should be confirmed by my more specific tests such as the indirect immunofluorescence assay IFA ELISA, enzyme-linked immunosorbent assay, complement fixation test, CFT are nowadays used over. That is about Weil Felix test.